Hello, everyone. My name is Samantha Lindsay, and today we're going to be discussing the aggressive treatments and strategies of obesity. I hope you enjoy. So, what exactly is obesity? Obesity is defined as a condition of abnormal or excessive fat accumulation in adipose tissue to the extent that health is impaired. Obesity is certainly a common but often underestimated condition of clinical and public health importance in many countries around the world. Adipose tissue, or fat, is an anatomical term for loose connective tissue composed of adipocytes. Okay, I know I said that pretty fast. Adipocytes, these are the actual fat cells themselves. When they join together and become connective tissue, we refer to them as adipose tissue, but the actual cell itself, the fat cell, is called an adipocyte. Brown adipose tissue. This tissue is primarily located beneath the skin, but it is also found surrounding internal organs. In terms of the skin, it accumulates at the deepest level, called the subcutaneous layer. This provides insulation from heat and cold. Around the organs, it provides protective padding. It also functions as a reserve of nutrients. When more energy is consumed than expended, much of the excess energy is stored in the fat cells of adipose tissue. The amount of fat in a person's body reflects the number and the size of the fat cells. The number of fat cells increases most rapidly during the growing years of late childhood and early puberty. After growth ceases, fat cell number may continue to increase whenever energy balance is positive. Obese people have more fat cells than healthy weight people. Their fat cells are also larger. When energy intake exceeds expenditure, the fat cells accumulate triglycerides and expand in size. When the cells enlarge, they stimulate cell proliferation so that their numbers increase again. Thus, obesity develops. When a person's fat cells increase in number, in size, or quite often both. The amount of excess fat in absolute terms and its distribution in the body, either around the waist and trunk or peripherally around the body, have important health implications. Popular articles sometimes call bodies with upper body fat apples and those with lower body fat pears. Researchers sometimes refer to upper body fat as android, man-like, and to lower body fat as gynoid, woman-like. So why do people accumulate excess body fat? The obvious answer is that they take in more food energy than they expend. But that answer falls short of explaining why they do this. It's genetic, it's environmental, cultural, behavioral, socioeconomic, psychological, and metabolic factors that all contribute to this condition. Although most cases of obesity don't stem from genetic mutation, genetic influences do seem to be involved. Researchers have found that adopted children tend to be similar in weight to their biological parents and not their adoptive parents. Studies of twins yield similar findings. Identical twins are twice as likely to weigh the same as fraternal twins, even when reared apart. These findings suggest an important role of genetics in determining a person's susceptibility to obesity. In other words, even if genes do not cause obesity directly, genetic factors interact with the food intake and the activity patterns that lead to it, and the metabolic pathways that maintain it. Researchers have identified an obesity gene called OB, spelled OB. This is expressed primarily in the adipose tissue and codes for the protein leptin. Leptin acts as a hormone primarily in the hypothalamus. Research suggests that leptin from adipose tissue signals sufficient energy stores and promotes a negative energy balance by suppressing the appetite and increasing energy expenditure. Changes in energy expenditure primarily reflect changes in basal metabolism, but may also include changes in physical activity patterns. Leptin is also released from stomach cells in response to the presence of food, suggesting a role for both short term and long term satiety regulation. Mice with a defective OB gene do not produce leptin and can weigh up to 3 times as much as normal mice and have 5 times as much body fat. When injected with a synthetic form of leptin, the mice rapidly lose body fat. Leptin is injected because it is a protein and would be destroyed during digestion if given orally. The fat cells not only lose fat, but they self destruct, reducing the cell number, which may explain why weight gains are delayed when the mice are fed again. Although extremely rare, a genetic deficiency of leptin has been identified in human beings as well. An error in the gene that codes for leptin has been discovered in a few extremely obese children with barely detectable blood levels of leptin. Without leptin, the children have little appetite control. They are constantly hungry and eat considerably more than their siblings or peers. Given daily injections of leptin, these children lost a substantial amount of weight, confirming leptin's role in regulating appetite and body weight. Leptin interacts with another protein that also acts as a hormone primarily in the hypothalamus. This is known as ghrelin. This protein is secreted primarily by the stomach cells and promotes a positive energy balance by stimulating appetite and promoting efficient energy storage. The role ghrelin plays in regulating food intake and body weight is currently the subject of intense research. Ghrelin triggers the desire to eat. Blood levels of ghrelin typically rise before and fall after a meal in proportion to the calories ingested, reflecting the hunger and satiety that precede the following eating. In general, fasting blood levels correlate inversely with body weight. Lean people have high ghrelin levels, and obese people have low ghrelin levels. Interestingly, although ghrelin levels are high in underweight people, they are exceptionally high in anorexic nervosa and return to normal with nutrition intervention, indicating that both body weight and nutrition status influence ghrelin levels. Other genes code for proteins involved in energy metabolism. These proteins may influence the storing or expenditure of energy with different efficiencies or in different types of fat. The body has two types of fat: white and brown adipose tissue. White adipose tissue stores fat for other cells to use as energy. Brown adipose tissue releases stored energy as heat. When fat is oxidized, some of the energy is released in heat and some is captured in ATP. In brown adipose tissue, oxidation may be uncoupled from ATP formation, producing heat only. By radiating energy away as heat, the body expends rather than stores energy. Brown fat and heat production is particularly important in newborns and animals exposed to cold weather, especially those that hibernate. They have plenty of brown adipose tissue. In contrast, most human adults have little brown fat. One explanation for obesity is that overweight people overeat, although diet histories may not always reflect high intakes. Diet histories are not always accurate records of actual intakes because both normal weight and obese people commonly misreport their dietary intakes. Most importantly, current dietary intakes may not reflect the eating habits that led to obesity. Obese people who had a positive energy balance for years and accumulated excess body fat may not currently have a positive energy balance. This reality highlights an important point. The energy balance equation must consider time. Both present and past eating and activity patterns influence current body weight. We live in an environment that exposes us to an abundance of high calorie, high fat foods that are readily available, relatively inexpensive, and heavily advertised. And they do taste pretty good. Food is available everywhere, all the time, thanks largely to fast food. Our highways are lined with fast food restaurants and convenience stores and service stations that offer fast food as well. Fast food is available in our schools, malls, the airports. It's convenient, it's available in the morning, noon, night, and at all times of the day. Most alarming are the extraordinarily large serving sizes and ready to go meals that offer supersized combinations. People buy the large sizes and combinations, perceiving them to be a good value, but then they eat more than they need, which is actually a bad deal. Large package or portion sizes can increase consumption even when the food is not particularly appealing. Moviegoers given stale popcorn ate more when eating from a huge container than a large container. Both sizes were greater than anyone could finish. Simply put, large portion sizes deliver more calories, and portion sizes of virtually all foods and beverages have increased markedly in the last several decades, most notably at fast food restaurants. Not only have portion sizes increased over time, but they are now 2 to 8 times larger than standard serving sizes. The trend towards large portion sizes parallels the increasing prevalence of obesity and overweight people in the United States, beginning in the 1970s, increasing sharply in the 1980s, and continuing today. Restaurant food, especially fast food, is a major player of the development of obesity. Fast food is often high in fat. Fat is 9 calories per gram, and that quickly adds up, amplifying people's energy intakes and enlarging their body fat stores. The combination of large portions and energy dense foods is a double whammy. Reducing portion sizes is somewhat helpful, but the real calorie savings comes from lowering the energy density. After all, large portions of food with low energy density, such as lean meats, fruits, and vegetables, can help with weight loss. Unfortunately, these foods may not be as inexpensive, flavorful, and convenient as energy dense foods. Restaurants can help their customers eat healthfully by reducing portion sizes and offering more fruits, vegetables, legumes, and whole grains. Physical inactivity also plays a huge role in contributing to obesity. Life requires little exertion. Elevators carry us upstairs, automobiles take us across town, buttons roll down windows, remote controls change television channels from a distance. Modern technology has replaced physical activity at home, at work, and in transportation. Inactivity contributes to weight gain and poor health. In turn, watching television, playing video games, and using the computer may contribute to most physical inactivity. The more time people spend in these sedentary activities, the more likely they are to be overweight. These sedentary activities contribute to weight loss in several ways. First, they require little energy beyond the resting metabolic rate. Second, they replace time spent in more vigorous activities. Third, watching television influences food purchases and correlates with between meal snacking on high calorie, high fat foods most heavily advertised. People may be obese, therefore, not because they eat too much, but because they move too little, both in purposeful exercise and in routines of daily life. One study reports that the differences in the time obese and lean people spent lying, sitting, standing, and moving accounts for about 350 kcals a day. Some obese people are so extraordinarily inactive that even when they eat less than lean people, they weigh a lot more. There are many increased health risks associated with obesity. Obesity can cause pulmonary disease such as sleep apnea, for instance. In adults, the most common cause of obstructive sleep apnea is excessive weight and obesity, which is associated with the soft tissue of the mouth and the throat. During sleep, when the throat and tongue muscles are more relaxed, this soft tissue can cause the airway to become blocked. Obesity can also cause non fatty liver diseases such as non alcoholic fatty liver disease or NAFLD. This includes simple fatty infiltration, a benign condition called fatty liver. Fatty liver is excessive accumulation of lipid in hepatocytes, where non alcoholic steatohepatitis, or NASH, is defined as the presence of fat leading to lipotoxicity and inflammatory damage to hepatocytes. Obesity can also cause gallbladder stones and gynecologic disease such as polycystic ovarian syndrome or PCOS. PCOS is one of the most common hormonal disorders in women of reproductive age, affecting 5 to 10%. Women with PCOS have irregular menstrual bleeding and often have difficulty getting pregnant. The syndrome occurs when levels of hormones are abnormal. The name polycystic ovarian syndrome refers to the appearance of small cysts along the outer edge of the enlarged ovaries of a woman with this condition. The exact cause of PCOS is unknown, but experts believe it is related to the production of an excess amount of androgens, a group of male sex hormones. Many factors play a role in the production of androgens and thus development of PCOS. For instance, excessive insulin, the hormone that allows cells to use glucose, may be a factor in developing PCOS. Excessive insulin leads to insulin resistance, which in turn decreases your ability to use insulin efficiently. When the body cannot use insulin properly, it secretes more insulin to make glucose available to cells. The resulting excess insulin is thought to additionally boost androgen production by the ovaries. Obesity also contributes to osteoarthritis, and it's the most common joint disorder with symptoms in the hands, knees, hips, and back and neck. It is unclear exactly how excess weight influences OA. Clearly, being overweight increases the load placed on the joints, such as knees, which increases stress, which could possibly hasten the breakdown of cartilage. Obesity is also associated with many forms of cancer, including colon, pancreatic, breast, uterine, esophagus, kidney, and prostate. Obesity increases the risk of hypertension, diabetes, stroke, and cataracts. Over the past 2 decades, the adult population in the United States has on average become much heavier. From 1987 to 2007, the fraction of adults who were overweight or obese increased from 44% to 63%. Almost two-thirds of the adult population now falls into one of those categories. The share of obese adults rose particularly rapidly, more than doubling from 13% to 28%. The sharp increase in the fraction of adults who are overweight or obese poses an important public health challenge. Those adults are more likely to develop serious illnesses, including coronary heart disease, diabetes, and hypertension. As a result, that trend also affects spending on health care. The recently updated 2013 obesity treatment guidelines include a treatment algorithm based on the 5A's framework: assess, advise, agree, assist, and arrange. This is an effective behavior change counseling model. Studies have shown that each additional 5A step delivered by physicians has been associated with higher odds of patients increasing their motivation to lose weight, change their diet, and start exercising regularly. In a recent study, physicians who used the 5A's showed a twofold increase in obesity management. The assess step involves screening for obesity comorbidities such as sleep apnea, chronic insomnia, chronic pain, depression, eating disorders, ADHD, and mental illnesses that are likely to interfere with weight loss, and the patient's willingness to make health behavior changes. This can be conducted by a medical assistant or nurse. The use of appropriate language without the denotation of stigma and shame is particularly important in the assessment step. The terms obese or obesity have been associated with patient stigmatization. Patients prefer providers to refer to their actual weight or body mass index or BMI. For example, a provider might say, "Let's discuss your weight today," or "Your current BMI puts you at risk for cardiovascular disease." Screening involves evaluating and informing patients of their weight status and risk factors for cardiovascular disease. Both BMI and waist circumference is a strong predictor of cardiometabolic risk and should be assessed. To assess readiness to change, ask patients things like, "Are you ready to take some steps to lose weight?" Or, "How does your weight impact your health?" Some patients may not be motivated to pursue weight loss due to having more pressing health or mental health issues, lacking confidence in their ability to control their weight, or experiencing serious financial problems or other challenging life circumstances. In this case, simple steps include making a plan to address certain issues, inviting the patient to let you know when he or she is ready, building the patient's confidence to make an effort towards weight loss. For the patient who expresses readiness to change, the steps include praising the patient who had a recent or past weight loss, even if their BMI is still on the overweight or obese range. Ask the patient about the past and current weight loss strategies and what is working and what is not working for them. Ask the patient how you may help in their weight loss efforts and acknowledge their values in linking weight to health issues. The advise step involves counseling the patient about the health risks associated with their current weight status and the health benefits of modest weight loss. Patients are often interested in learning how their weight affects specific medical conditions. Physicians should inform patients that while individual studies have found benefits from low fat, low carbohydrate, vegetarian, and Mediterranean diets, the collective literature conclusively indicates that no single diet is best for weight loss. Patients should be advised to select diets or to make gradual dietary modifications based on their specific needs. Regardless of the dietary approach chosen by the patient, Patients should be encouraged to reduce their energy intake by 500 to 1,000 calories a day via diet and exercise. Although patients will vary in the calorie reduction required to lose a pound, physical activity is a central component of lifestyle interventions and, even in the absence of weight loss, can result in significant improvements in cardiometabolic health. The third step is the agree. Goal setting is a key health behavioral change strategy. Appropriate behavioral goals are specific, measurable, attainable, relevant, and time based. An example of a goal is I will walk for 30 minutes 3 times per week, whereas I will exercise more is not a great example of a goal. Patients often have unrealistic weight loss goals, which can increase the risk for feelings of failure and disappointment. The Agree step involves a collaborative approach to setting realistic goals. An initial weight loss of about 5 to 10% of weight is recommended for overweight and obese adults. For most patients, this implies a weight loss rate of 1 to 2 pounds per week. Self monitoring of weight, nutrition, and physical activity is also essential for behavior change and has been associated with improved dietary choices, practices, increased physical activity, weight loss, and weight maintenance. A multitude of commercial mobile applications are available to assist in dietary and physical activity self monitoring. During the assist step of the 5As, a physician is encouraged to help identify the barriers that the patient is experiencing in achieving each of their behavioral goals and developing a plan with clear strategies to overcome these barriers. An acronym repeating the steps of the problem solving is ADAPT, which stands for attitude, define the problem, generate alternative solutions, and predict consequences, and last, try out and evaluate the solution. Use of problem solving skills is associated with significant weight loss in treatment programs. During the last step, arrange, a physician is told to increase accountability through regular, monthly, weekly follow up visits. This is critical to maximizing success. In follow up visits, physicians should assess the patient's progress with their goals, review self monitoring records, help the patient problem solve any barriers encountered since the last visit, and review progress on referrals made. The pace of weight loss varies across patients, with some losing 1 to 2 pounds weekly and others experiencing slower or negligible weight loss with frequent plateaus and occasional regains. Patients with slow or negligible weight loss in the first month should be referred for more intensive counseling of behavioral health or nutrition providers. During this step, the physician is encouraged to build a multidisciplinary care team. This is healthcare professionals like nurses, medical assistants, dietitians, psychologists, or just a health educator combined with the primary care physician's oversight. And this includes quarterly visits, and this is more likely to produce clinically significant weight loss. A low energy diet recommended for treatment of obesity should be low fat, high carbohydrate, and high protein and high fiber. A high carb, low fat, energy deficient diet is usually recommended for weight management by medical societies. It also should be considered that the ratio between saturated, monounsaturated, and polyunsaturated fatty acids in ingested fats influences metabolic and cardiovascular risks of obesity, including insulin resistance. Diets with strict limitation of energy intake leading to semi-starvation should be strictly avoided because of serious health hazards that relate to deficiencies of several nutrients. Physical activity should be an integral part of the comprehensive obesity management and should be individually tailored to the degree of obesity, age, and presence of comorbidities in each subject. Physical activity not only contributes to an increased energy expenditure and fat loss, but also protects against the loss of lean body mass, improves cardiorespiratory fitness, reduces obese related cardiometabolic health risks, and evokes sensations of well being. Aerobic physical training leads to improvement in oxygen transfer to muscle, which promotes an increased utilization of abundant fat stores instead of the limited glycogen stores. Physical activity of a moderate intensity, 30 minutes in duration, performed 5 days a week, is recommended. Obesity is usually a result of lack of daily habitual physical activity. Therefore, activities such as walking, cycling, and stair climbing should be encouraged. Psychological factors influence both weight loss and, more importantly, long term weight loss maintenance. Behavioral modification of lifestyle should be included in the weight management strategies. Behavioral management includes several techniques such as self monitoring, stress management, stimulus control, reinforcement techniques, problem solving, rewarding changes in behavior, cognitive restructuring, social support groups, relapse prevention training. The list goes on. Behavioral therapy can be provided in clinical and commercial settings or as self help programs. Behavioral treatment of obesity in children should address the whole family or at least the mother of an obese child. Behavioral modification of lifestyle, especially self control over daily energy balance, plays a crucial role in long term success of weight management. Self monitoring weight, dietary intake, and daily physical activity on a regular basis is an important determinant of weight loss maintenance. Consistent patterns of eating, including regularly eating breakfast, also influences the outcome of weight management. Anti obesity drugs have been developed to assist weight loss in combination with lifestyle management to improve weight loss maintenance and reduce obesity related health risks. Pharmacology of obesity should be applied as a part of the comprehensive obesity management, which includes lifestyle modification. About 11 years ago, there was an article published detailing long term weight management with the use of only 3 anti-obesity drugs. The first medication is called sibutramine. As a serotonin and norepinephrine reuptake inhibitor, this medication induces satiety and provides diet induced decline in metabolic rate. Another medication is called orlistat. As an inhibitor of lipase, this reduces fat absorption in the intestine. The third medication is called rimonabant. As a selective cannabinoid receptor blocker, it reduces food intake and can suppress tobacco dependence by blocking cannabinoid receptors in the central nervous system, and this affects the metabolic profile by targeting the cannabinoid system in adipocytes and hepatocytes. Rimonabant administration leads to significant weight reduction and improvement in cardiometabolic risk profile. 4 new medications have been FDA approved since 2012. They include Casemia, which is a combination of phentermine and topiramate, Belviq, which is called Lorcasen, Contrave, which is a combination of naltrexone and bupropion, and Saxenda, which is also called liraglutide. Specific criteria established by the NIH consensus panel indicated that Bariatric surgery is appropriate for all patients with a BMI greater than 40 and for patients with BMI 35 to 40 with associated comorbid conditions. The first bariatric surgery is called the Roux-en-Y gastric bypass. In this procedure, the stomach is transected, creating a gastric pouch of approximately 1 ounce capacity. This diverts ingested nutrients from the body of the stomach, duodenum, and proximal jejunum. The vagal trunks are not disturbed, but a variable number of branches to the body of the stomach are divided in the process of dividing the stomach. There can be associated endocrine changes. For example, malabsorption of energy-containing nutrients is minimal, if any. Malabsorption of calcium, iron, and B12, and possibly other macronutrients can occur. Another procedure is called the vertical sleeve gastrectomy. In this procedure, approximately 80% of the body of the stomach is resected, creating a tubular stomach based on the lesser curvature of the stomach. No gastrointestinal to small intestine anastomosis is required. Although some restriction on food may occur, gastric emptying is accelerated. A more complex procedure called the biliopancreatic diversion with duodenal switch is similar to a sleeve gastrectomy. This procedure goes a step further. An anastomosis between the proximal duodenum and bypassed intestine is accomplished, thereby creating a degree of malabsorption of nutrients. This procedure is infrequently performed due to higher incidence of short and long-term complications. There's also an adjustable gastric band. An adjustable gastric band is placed around the proximal stomach to constrict the size of the gastric pouch and outlet. The rate of gastric emptying can be adjusted by a balloon connected to a subcutaneous port. Another option includes intermittent vagal blockade. In this procedure, leads are placed around the vagal trunks at the diaphragm to produce intermittent vagal blockade. Weight loss occurs by reduction of appetite and establishment of early satiety. The intermittent blockade is hypothesized to avoid neural adaptation, as occurred in the past with truncal vagotomy. A device for this purpose has been approved by the FDA. There are also gastrointestinal endoscopic devices. While several endoscopically placed devices or suturing procedures are under development, placement of gastric balloons has recently been approved by the FDA. The information in this video was taken from these 7 sources above. So, to conclude, obesity is a complex disease involving an excessive amount of body fat. Obesity isn't just a cosmetic concern. It's a medical problem that increases your risk of other diseases and health problems such as heart disease, diabetes, high blood pressure, and certain cancers. There are many reasons why some people have difficulty avoiding obesity. Usually, obesity results from a combination of inherited factors combined with environment and personal diet and exercise choices. The good news is that even modest weight loss can improve or prevent health problems associated with obesity. Diet changes, increased physical activity, behavioral changes, all of these things can help you to lose weight. Prescription medications and weight loss procedures are additional options for treating severe cases of obesity. I hope you guys enjoyed. My name is Samantha Lindsay, and today we've discussed the aggressive treatments and strategies of obesity. Take care.